It's a joint effort total joint replacement class here at Trident. My name is Ashley. I am the clinical coordinator up on the 6th floor, which is ortho neuro. It is the floor you will be going to after your surgery. Brett Peterson is in the back. He is over inpatient rehab, so you will see him or some of his people during your hospital stay. This class is very informal and such. You guys are certainly welcome to eat as I speak. If you can't hear me, please let me know and I'll try and raise my voice a little bit louder. If there's any questions over anything I go over, you can stop me at that time and ask your questions. We'll cover that information. Other than that, we will get started because I do know some people have testing to go to afterwards. We have got 4 orthopedic doctors that do total hips and total knee replacements here at Trident Hospital. We have Dr. Zimlick, who does predominantly on Mondays. We have Dr. Stem, who does every other Tuesday. Dr. Kufferman does Thursdays, and we have Dr. Dalton, who does Tuesdays here at Trident. Dr. Stem also does over at Somerville Medical Center. He does every Monday over there. Those are pretty much their set days, but at different times and different months, sometimes they pick up another day. So if your surgery is scheduled with one of those physicians on a different day, don't be alarmed. They do pick up other days and kind of fill in their spots. All physicians are very good. They may have slightly different approaches, but the outcomes are the same. So the goals of the joint replacement program is, of course, we want to control your pain. We want to restore motion and mobility. We hope for successful outcomes, providing of excellent care, and also satisfaction with your overall experience. And when we're talking about the overall experience, we're talking from this point on, okay? With restoring motion and mobility, our goal for you is basically to get you back doing the things you enjoyed doing before your knee and your hip kind of went bad. If it was playing tennis, we want to get you back playing tennis. We want to get you back playing golf. And for some people, it just might be walking in general. So that's our goal for you. We want to get you back to doing those things that you enjoyed doing. In this class, we're going to talk about things that you need to know before surgery. A little bit about in surgery. I do not get very specific into the actual procedures just because that needs to come from your surgeon. And we'll talk about your recovery after surgery and then your plans for discharge. Ways to prepare, of course, for surgery is your pre-admission testing, which I know some of you have already gone to, some of you still have to go. And then usually the last step is attending the total joint replacement class. Let's get started. So is your home ready for your new joint? When we talk about this, we're not saying put your house on the market and go find something more suitable to your new knee and your new hip. But what we are talking about is think about your household. Look at your general household. Do you have 1 story? Do you have 2 stories? How many stairs do you have? Do you have stairs to get up into the house or just stairs to get up maybe to the 2nd floor? What kind of bathroom do you have, especially the tub area? Do you have the walk-in shower? Do you have the normal tubs that you have to step over the ledge? And then in the kitchen, look about how your kitchen is set up. Do you have enough room to get around? When you guys go home, you're going to be going home at a walker level. Typically, it's a rolling walker. So look at your house and make sure you have enough space to get around and maneuver where you're safe. A big thing is to pick up any throw rugs. Sometimes those throw rugs like to curl up on the edges and it can cause you to trip and fall, even if you're not using a rolling walker, just in general. So it might be a good idea just to pick those rugs up, put them away for the time being for about 3-4 weeks until you're safe and you feel comfortable enough getting around your house, okay? Again, in the kitchen, if there's things that you do in the kitchen where they may be up on the high shelves, you just might want to move them down for the time being. Again, this isn't stuff you have to keep, but just stuff to make that transition from the hospital to home to where you're comfortable again. Be thinking about how your household is set up. When physical therapy comes in to do their evaluation and their assessment, they're going to ask you these specific questions, and then they're going to tailor their plan towards that, okay? A big thing I do know is stairs. You're not going to be allowed to be discharged, or the doctor won't discharge you until you're safely moving up and down stairs, okay? When you're packing your suitcase, some things you may want to include, personal hygiene items. You certainly don't have to, but some people feel a little bit more comfortable bringing their own things. We do here in the hospital have toothpaste, toothbrushes, soap, and stuff like that, but you certainly are welcome to bring your own stuff if you'd like. Non-skid rubber-soled shoes. Bring a good pair of shoes. They can be a good pair of house slippers. We don't want anything that your foot can flip out of that can cause you to trip. Nothing without a back, so flip-flops, some sandals that don't have the backings in them. Crocs aren't usually pretty good just because they are wide enough to where they're comfortable on your feet, but the toe catches a lot of times and can cause people to stumble and trip. But you want something that's going to be good on your foot and solid on your foot. You will be walking out into the hallways with physical therapy, so you want something that's going to get you around good. Gym shorts and t-shirts. Women, if you want to bring robes, nightgowns, it's basically, again, whatever you feel comfortable walking out in the halls with. Of course, we have the hospital gowns for you. We can provide another one just to kind of cover up the back if you need to. But anything that you feel comfortable being out in the hall with, okay? Shorts and stuff. If you do bring shorts, or even maybe women crop pants, capri pants, something like that, you want to make sure you have an elastic band. Whatever side you have dressing on, you will have a bulky dressing, so you want to be able to pull it up comfortably over your dressing, okay? A lightweight robe is certainly welcome, and then anything else that you desire to make you feel more comfortable here. People have brought in books, some people bring in laptops, of course your cell phones are welcome, so anything that's going to make your stay here in the hospital a little bit more better, okay? Things that we do not want you to bring to the hospital, we ask that you don't. Please no valuables such as money, credit card, checkbooks, or jewelry. Now jewelry, I know that if you're married, or even women, we like to wear the little stud earrings, we like to wear wedding rings, things like that. You can certainly have that stuff on after your surgery. But when you go into the operating room, that stuff needs to come off, okay? Give it to somebody that you trust. When you get back up on the 6th floor and you're stable, you certainly are welcome to put that stuff on, okay? Money, credit card, and checkbooks you certainly do not need while you're here in the hospital, okay? We don't want you to bring any home medications, okay? However, we do want you to bring us a current list of your medications, includes your dosage and your frequency, the type of medication that it is. You're going to be asked for this list quite often, okay? You may have already been asked for it in your pre-admission testing. You're going to probably be asked for it in your registration. But up on the 6th floor, we really like to have a copy of it as well. And all we're doing is verifying what the doctor has ordered for you is exactly what you're supposed to be taking. If for some reason the hospital does not have a medication here, meaning that it's non-formulary in our pharmacy, at that time a nurse will come and ask you if you can have somebody please bring it in. What we do is we send it down to pharmacy. When you get ready to be discharged, we go down and pick it up. But the pharmacy will dispense it like you're supposed to take it. If you're supposed to take it twice a day, we're going to give it to you twice a day. It doesn't happen on a lot of medications, but there are some that we do not carry here. But you'll be notified on an individual basis by your nurse, okay? Pre-operative instructions. Nothing to eat or drink after midnight. No smoking the day before surgery. Shower with your Hibiclens wash and shampoo your hair. I've seen some of you guys come in from your pre-admission testing with this. This is your Hibiclens wash, okay? What you're going to do with this is you're going to wash your entire body the night before your surgery and the morning of your surgery. You want to wash your entire body with the exception of your face and your private areas. Do not use this on your hair. Go ahead and wash your hair with your normal shampoo and conditioner, whatever you use. But then instead of using soap, use this. This is our first line of defense against infections from building up before the doctor makes an incision. It pretty much just cleans that bacteria off of your skin, so it's a nice cut, clean incision, okay? Again, night before, morning of. If you have not already received this and you've gone to your pre-admission testing, you may want to just step back there and see if they can give you some, okay? No makeup and no nail polish. Remove all jewelry, including your body piercings. And then the anesthesiologist or even your orthopedic doctor will let you know what medications to take the morning of your surgery. You're not going to take all the meds you're typically used to taking. You're going to probably end up taking a beta blocker, which is a blood pressure medication. You're going to take any hormone replacement. So if you're on Synthroid, you're going to want to take that. And then anything that you may be on for your stomach, any acid reflux, GERD, anything like that, you're going to go ahead and want to take as well. For some reason, if we can't get your oxygen saturation level on your finger, we're going to go to your toe. And most of the times it just will not pick up on a colored enamel, so that's why we like to have the polish off. Any questions about the medications? A big thing, if you are a diabetic, do not take your medications in the morning. And the reason is because you haven't had anything in your system from the night before. We don't want your blood sugar to plummet out before you can go into the operating room, because then they'll put off your surgery for a little bit, okay? So the day has arrived. You want to arrive to the ACC, which is the Ambulatory Care Center, at your scheduled time. But the morning of your surgery, what you want to do is come in and pass the ER parking, and your next parking lot's right there. And that's actually where you want to park that morning. You will be notified the day before your surgery, or if your surgery is on Monday, you'll be notified Friday to let you know what time to arrive to ACC, okay? Once you get here, you get checked in, a nurse will come out and escort you back into the ambulatory care room. What you can expect there, at this time, we only ask that the patient goes back, not the family members. And the reason is because we're going to get the patient ready to go straight into the OR. We're going to get you in a hospital gown. If you need oxygen, we're going to start oxygen on you. We're going to go ahead and start an intravenous and IV line on you. We're basically just going to get everything ready so you can roll right into the operating room. Once you're ready to go in, family members can come in at that time, okay? And the wait goes on. Once the patient has been taken from ACC into the operating room, we ask that any family members or friends that come to kind of stay in that ACC waiting area. That is our surgical waiting area. And the reason is because if something were to happen, not saying it's going to, but somebody can get a hold of you. On top of that, nurses can call and give you updates from the operating room, saying where the patient is in the procedure, how things are going, and you can kind of just keep track of that. Also, in the ACC waiting area, you have a monitor, and on that monitor is the physician's name, and the first 3 letters of the patient's last name. That way you can also, again, track how the patient's doing, where they are. It'll say if they're in the operating room, out of the operating room, still waiting for the procedure to start, those kind of things. So you can kind of keep track. Surgery time is typically an hour to an hour and a half. If it goes beyond an hour and a half and you're a little bit alarmed, usually there's a volunteer in there or also somebody at the registration desk. You can go and ask them, hey, can you please check on so-and-so? You may not know the operating room number, but they can at least call into there, see what's going on, and give you a little bit of peace of mind, okay? After surgery is complete, the patient's going to go directly from the OR to the recovery room. In the recovery room, we typically give about 2.5 hours, and the only reason is dependent upon the patient. We want the patient to wake up from anesthesia. We want to go ahead and get pain medication on board. Basically, we want to make sure that you're waking up okay, your vital signs are staying stable, your blood pressure is good, oxygen levels are good, before they wheel you on up to the 6th floor, okay? Your family members will already know what room number you're going to on the 6th floor, so they can go on up to the 6th floor and wait for you there. Once you're done in recovery and they feel that you're safe enough to come on upstairs, you'll come on upstairs into your room. At that point, we will ask family members to step out long enough just for us to get you settled in the room, and then they can quickly come right back in. Room assignments up on the 6th floor are all going to be private rooms, okay? You will not be sharing a room with anybody, nothing like that. If you are lucky enough to get a semi-private room, just know nobody will be in the bed next to you except maybe a family member. If they'd like to stay the night, they have the opportunity to stay the night with you. The single rooms, the private rooms, are set up where somebody can stay the night with you as well. So don't be alarmed if somebody wants to stay with you. You're certainly welcome for that. We'll make all the accommodations and make you feel comfortable, okay? But just don't be alarmed. We do not put our surgery patients with another patient, okay? Some possible ways to control your pain. Unfortunately, I cannot tell you the surgery is going to be without pain because, 1, I've never had it, but, and 2, just from past patients. But we do everything that we can to control your pain. We can't take it away, but we will try and control it the best that we can, okay? A couple ways we do that. If you're having a knee, you will have a nerve block. One of the nerve blocks is going to be a femoral nerve block, where you get a catheter or a one-time shot in the femoral area. It's going to help to keep the top part of your knee a little bit numb. I have 2 doctors that use a catheter, so it will stay in place for a couple days. The other doctors just use a one-time injection, both effective, okay? The other injection, and it's always a one-time injection, is going to be a sciatic nerve block. And it goes in the back part in the sciatic nerve, and it helps to keep the back part of your knee kind of numb, okay? You'll get these the day of your surgery, before your surgery. You'll start to feel them wear off, especially if they're one time. If they're the catheter, you shouldn't feel the top part as much as you will the back, but you'll start to feel those wear off probably about 6 to 8 hours after your surgery. So if you know that in advance, if your surgery is 7 o'clock in the morning, by that night, definitely by 1 or 2 in the morning, you're going to start to feel it, okay? Especially the back of the knee. Back's where you're going to feel it first. What you're going to do if you start to feel it and you become uncomfortable, or before actually you get to the point you're uncomfortable, go ahead and let your nurse know so they can get you something else so we can get that pain under control, okay? Hips, unfortunately, I do not have a nerve block for, but we do get pain medicine on board as quick as possible. I have a couple of doctors that also use a patient-controlled analgesic, which is basically a pain pump. We're going to put medication in the pump. We're going to give you the button, and you can push the button yourself. Okay? It is set up in such a way that it will not overdose you. However, it is very, very important that only the patient pushes the button. Okay? Some people are very sensitive to narcotics, especially waking up from anesthesia and stuff. It can make you very, very tired. Okay? So we don't want anybody else to push that button other than the patient. We'll teach you that a little bit more once you get up to the floor. And those can be used on hips and knees. Okay? So depending upon your doctor, depends on if you get that, and it will be on both. We also can do an intramuscular injection with morphine or Dilaudid, where it goes into your deltoid area, your upper arm. We also can do IV medication where it goes through your IV, and then also pain tablets. Now our goal is to get you on the medicine by mouth as quick as possible. Now, if you come up to the floor and you're very nauseated, not taking anything by mouth or anything like that, we're not going to push pain medicine by mouth on you right away. We have other ways to control your medicine. But the reason we try to get you on the pain tablets as quick as possible is because when you go home, that's what you're going to have. You're not going to have an IV line. You're not going to have injections to give yourself, okay? So, of all these methods, when you're going through the process and you're working physical therapy and stuff like that, if something's not working for you, please let us know. We can call the doctor, we can call the physician, we can get something changed up for you. When I say we're trying to control your medicine or your pain, we can't knock it out. And the reason is you've got to work with physical therapy. It's very, very important with your hips and your knee that you work with therapy. Okay? We're not going to deny you medication, but we're going to talk with them and collaborate with them on when they're going to come work with you, when we can give medicine, if it's time. We just don't want you to be too sleepy to where you can't work with therapy, okay? That's why I say it's very important we control it. We can't take it away. Again, we're going to do the best that we can, but we need you guys to talk to us, tell us what your levels are, how we can help you. If you know something works better for you that you're not getting, let us know. We can call the doctor as well. Gadgets and gadgets. When you come up from the PACU or recovery room, you're going to have all kinds of things hooked up to you. You're going to definitely have an intravenous line, your IV line, that's going to have fluid. If you have a PCA ordered, your PCA is going to hook up to that IV line. Okay. Nasal cannula to provide oxygen. If you come up to the floor with nasal cannula on, giving you some extra oxygen, do not be alarmed. You will not go home with this. This doesn't mean anything other than we're trying to wake up your lungs and wake up your body to take those good deep breaths in. So we're just going to give you some extra oxygen until your body's awake enough to take those deep breaths, and we can take it away. Okay? So usually majority of our patients do come up with it. So again, don't be alarmed, you're going to go home with it. Okay? Typically it's gone by that night or the next morning. SCDs, sequential compression devices. These little sleeves are going to be placed around the calves of your legs, both legs, operative and non-operative, okay? And what they're going to do is they're going to be hooked up to a pump on your bed. They're going to constantly inflate and deflate. And all it's doing, it's helping to move that blood, especially in your calf area, back and forth. Anytime you're immobilized for a certain amount of time, you have a large surgery, anything like that, you run the risk of a blood clot. So this is our first line of defense against preventing blood clots. While you are in bed, these need to be hooked up to the pump and working. Most likely you're going to feel it more on your non-operative leg than your operative leg, but it will be on your operative leg as well. Okay? Again, it's constantly moving that blood back and forth. Another thing we're going to teach you to do up on the floor is ankle pumps. And all you're doing there is you're moving your ankles up and down. You can do that at any time, here in the room, at home, whatever. Again, it's helping moving that blood back and forth so it's not staying stationary in one spot. Okay? These might seem, you know, not that important, but they really are important. It's very important if you are in the bed, these are on. If you're sitting up in the chair, they don't need to be on. If you're up walking, they certainly don't need to be on because that blood's moving, okay? If you are a knee patient, you will get a knee immobilizer. You will either come up from PACU with this already on, or you will get it by the end of that day. What it does, it's going to help to keep your knee straight. It's more important to be used when we go to get you up. That day of surgery, we're going to get you up. Now, we might just sit you at the side of the bed. We might get you up to the bedside commode. We might even get you up to the bathroom. It's dependent upon how well you feel. You're not going to have a lot of feeling in that leg, so you're going to need to have this on. Okay? It's going to help that knee from buckling and you going down. physical therapy comes in and you don't have this on, that's okay. They're going to do their own assessment and their own judgment to see if you need it, okay? Because they're going to walk you in the halls and stuff without this. But I'm going to tell you, if my nursing staff is getting you up, I would like for this very much to be on. I'm going to tell you something. And I'm not doing this to scare anybody or anything like that. But the reason this is so important is, especially post-op day 1 or 2, you're going to feel really good. You're going to feel better than you probably have in a while. You're going to still have a little bit of pain, but it's going to be very different before your knee was replaced. I had a patient on the floor that felt that way. She's doing very well, worked with physical therapy, came back to the bedroom, was doing her own thing, thought she could get up and do what she normally would do at home. She fell. Not only did she not use the call bell, which is very, very important, I want you guys to use the call bell. Harass the nurses. I don't care. We need to help you guys do stuff. But she also didn't have the knee immobilizer on and in place. She went down on that surgical knee, it opened back up, and she went right back to surgery. Okay? And I'm not telling you that to scare you. Again, I'm letting you know that this is very important. When therapy comes in, again, they use their own judgment and their own assessment. Okay? Nursing, or just in general, if you're getting up, I want you to use the call bell and I want you to ask for assistance. Okay? For my hip patients, you will come up with an abductor pillow in place. You will come up from the recovery room with this in place, okay? This goes, who's my hips? I got one here and there was you? Okay, so it's gonna go in between your legs like this, and it keeps your legs aligned in this position, okay? With a hip replacement, there are some precautions you have to follow. It might be anterior precautions or it might be posterior precautions. And your packets that I've given you, I've listed both of the precautions. Just become familiar with both of those. When the physical therapy come in, they're going to talk to you about your specific precautions so you can become more aware of them, what they are. But it's having to do with bending a certain way, crossing your legs, things like that. The abductor pillow is in place to kind of remind you that you can't cross your legs to keep in that position, okay? When you're in bed or even sitting in the chair, it's very important that maybe that's there. The doctors want it to be in place and loosely, the straps loosely around, okay? They don't have to be so tight to where you cut off circulation, but they need to be fastened, okay? When you walk with physical therapy, it will not be in place, okay? But again, they're gonna teach you those specific precautions that you need to learn and become familiar with, even when you go home, okay? And then a Constivac or a Hemovac. All of our incisions come up, knee incisions or even a hip incision come up with some type of drain in place. And all that is anytime you have a major surgery, we put a drain in place just to get that excessive fluid out of your body so it's not building up in there. We just monitor a Hemovac. We pretty much will see how much is coming in, dump it out, and we just kind of keep track of it. It usually comes out the next morning. A Constivac is a little bit different. I have one surgeon that uses it, and he uses it only on knee patients. It's kind of a neat device because it is a closed system, meaning that whatever it puts out, we can reinfuse that back into you. It's your blood, it's whole blood, okay? But we have certain guidelines on the floor in order for us to reinfuse it. It has to be within a certain amount of time, and it has to have a certain amount of drainage before we reinfuse it back. The nice thing about it is if we reinfuse it back, it may prevent you from having to have a blood transfusion later on in your stay. It may not, but it's a precaution we can do to make you feel a little bit better that day of surgery, okay? For the most part, all of these are discontinued or disconnected from you morning of post-op day 1, with the exception of your SCDs, your abductor pillow, and your knee immobilizer. Those are going to kind of stay in place or stay around you for your time in the hospital. Some information regarding your hospital stay, frequent monitoring. We're going to have staff in your rooms quite frequently. It's going to be either a nurse, it's going to be a tech, okay? They're coming in just to check on your vital signs, making sure you're staying stable. We're going to be checking on your pain level. We're going to be checking around your dressing, making sure that that's okay as well. So we'll be in there quite a bit with you, okay? Diet. After surgery, especially the day of surgery, we want you to start off kind of slow. We don't want you to get your lunch tray and think, oh my gosh, I'm so hungry. I hadn't had anything since the night before, and just guzzle that down. You might regret it. So start off kind of slow. Make sure you're tolerating everything first before you advance your diet. You're certainly welcome to advance it as you'd like, but we just recommend that you start off kind of slow and making sure you're tolerating everything. If you do come up to the floor very nauseated and even having episodes of vomiting, let us know, because there is medication we can give you as well to help you feel a little bit better. Fluids. Do not be alarmed that you're going to become dehydrated if for some reason you aren't tolerating anything by mouth and you are having episodes of vomiting, because you're going to be having your IV fluids going. They're going to stay in place. The next day when they're supposed to go away, if you're still having those kind of episodes, we're not going to take the fluid down until we know you're tolerating by mouth. Okay? Coughing and deep breathing. Every patient will be given an incentive spirometer. Okay? Again, it doesn't look like much, but it does a lot of good. Whenever you're put to sleep under general anesthesia, everything tends to follow sleep. The lungs are a big thing. So we want to help those lungs wake up. What you're going to do with the incentive spirometer is you're going to take a deep breath in and exhale. Your next deep breath in, your next inhale, you're going to inhale on this, okay? So you're going to take that deep breath in and inhale. You're going to see these things move up and down. You can set yourselves little goals, things like that. And it may produce a cough. It may cause you to want to cough. Do not fight that cough. We want it to cough. We want you to get any of that fluid out of the bases of the lungs. We want to get it out, okay? We do not want post-op pneumonia to set in. So we encourage you to use this as much as possible. The doctors will actually encourage you to use it every 15 minutes while awake. Some people use it maybe 4 or 5 times at the beginning of an hour or at the end of an hour, whatever works for you. I say if you're a TV watcher, every commercial, do it like 3 or 4 times. Wait till the next commercial and do it again 3 or 4 times. Again, you want to use this as much as possible. It's going to help those lungs take those good deep breaths in, move that fluid around so it's not setting in one spot. Possible complications from surgery. One, of course, is infection. Again, our infection rate is low. We do a lot of things to prevent infections from happening. The first step was that Hibiclens wash, where you're going to wash the night before your surgery and the morning of your surgery. In the operating room, before the doctor makes any type of incision, he's going to give you antibiotics through your IV. After that, once you get up to the floor for the next 24 hours, we're going to continue with IV antibiotics. That pretty much kills anything that can start. Okay, so after that, you're pretty much covered. Now, I put procedures and dentist under this because after you leave the hospital and you have even a dental cleaning, you're going to have an outpatient procedure that's invasive, anything like that, you need to let that physician or that dentist know that you've got a new knee or a new hip. They're going to need to give you an antibiotic before they do anything. It's going to be a one-time dose, it's prophylactic, and it's very important that you do it. And the reason is because when you do an invasive procedure or even a dental cleaning, you're running the risk of introducing bacteria into the bloodstream. What it does is it kind of travels through the body and it looks for something foreign. What's foreign is going to be that new knee or that new hip, and it can set up an infection around that area. Okay? So from this point on, after your surgery is complete, you need to let them know, and they're going to need to give you antibiotics. Okay? Blood clots. Again, this is another complication. You're immobilized for a while, you're having a large surgery. We do the SEDs. Again, they need to be on when you're in bed. Do ankle pumps when you're in bed. If you're in the chair without SEDs, do ankle pumps. Okay? Another way we do prevent blood clots is giving you something by mouth. We give you a blood thinner. Okay, I know some people may be on aspirin or Plavix. Most of the times the doctors will stop those while you're here in the hospital. They'll put you on a medication called Xarelto. It's a pill. You take it for 12 to 24 days depending upon which type of surgery you're having. And again, all it's doing is help keep that blood a little bit thinner, just so no clots can form. Once you go home, we'll tell you things and risk to watch for with that blood thinner. And then once you're stopped with it, there's nothing more you need to do, okay? But it's very important that you follow the regimen and you take the prescription as ordered. And then again, pulmonary complications. This is where we're using the incentive spirometer. This is where we're getting you up and moving. We don't want you laying in that bed. If it means just sitting in the chair for a good part of the day, we want you to do that. We just don't want you laying flat, okay?
My name is Brett Peterson, as Ashley had introduced me earlier. I am an occupational therapist and I supervise the inpatient rehab department. Rehab is going to play a very important role in your outcome. Okay? At the last class, I had a patient raise their hand and say, Brett, how long do I need to be doing my exercises? And my response was, this needs to be a lifestyle change and it needs to be done forever. Okay? That's what we're looking for. We're looking for you to incorporate a new lifestyle with exercise. Many of you may already do that at this point. But for those that don't, we're going to encourage that you develop that program. Okay? Your rehabilitation is going to start immediately. Okay? The day of surgery, when you get up there, Ashley had talked about nursing getting you on the side of the bed and getting you moving again. Okay? Sometimes we come up and we hear, well, don't you know I just had surgery today? Absolutely. And research tells us that the faster that we get you moving, the better your outcome will be. Okay? Physical therapy will come to see you the day after your surgery. They'll see you in the morning, and what we'll do is we'll do an evaluation with you. Okay? We'll test your strength, your balance, your coordination. We'll develop an individual plan to meet your needs. Okay? We'll work closely with nursing to manage your pain. We'll work closely with the physicians for your discharge plan and case managers. Okay? After we do an assessment with you, we're going to teach you some exercises. And listed in your booklet are exercises on page 26 and page 30. I would like you to make yourself familiar with those exercises because those are the first ones that we're going to review with you. Okay, so if you want to look real smart in front of your physical therapist, please review those and give them a try. Okay. We're going to get you up and moving, okay, and depending on how you're doing is how far we'll go with you. Okay, we may only have you to transfer to a chair in the morning. We may get you to walk 50 feet, or we may get you to walk out to the nurses' station. Okay? It's all going to be dependent on how you're doing. We're going to leave you up in the chair for a while, and it's going to feel like you're up there for eternity. It's going to seem like you're there for maybe 4 or 5 hours. Okay? And then we're going to come back and work with you in the afternoon. Okay? A lot of times in the morning, you may feel like, wow, I think I could have done a little bit more. But rest assured, we're going to pace you for some more intensity in the afternoon. Don't be surprised in the afternoon if we get you on the stairs and do stair training with you. You'll progress that quickly. Okay? So key takeaways, we're going to see you twice a day, every day while you're here. Okay? We're going to work closely with nursing to manage your pain. Know that when that pain does increase, you need to keep them informed of how you feel. Okay? I don't want you to fight it with it. I want you to let them know how you feel with that pain. And then as Ashley had touched upon, please call for help. Okay, we're here to help you out. We want to be with you when you're doing your transfers, no matter how well you feel you're doing. Okay? Occupational therapy is going to work with you as well. And what an occupational therapist does is we come in and we evaluate what we call your activities of daily living. How are you doing with your dressing, your bathing, your grooming? We want you to be as independent as possible. Okay? Our expectation is for when you go home or move on to the next level, that you'll be able to do those skills it yourself, okay? Sometimes I hear that, well, I have a family member or a husband or a wife that can help me put that sock on. We want you to be able to do that yourself, and that's part of your rehabilitation, okay? We may use adaptive equipment to teach you how to do that so that you're able to get that completed, okay? Well, depending on how you do it. Okay? Equipment. We're going to make recommendations for what equipment we feel would best suit your needs. Okay? A lot of times we'll make recommendations for a bedside commode or a tub bench. A majority of you folks will be going home with a walker. Okay? Don't go out and purchase the equipment at this point. All right? We'll be working with you to set that up.
We do anticipate people to go home. However, we do know that there are circumstances that you don't have somebody there with you that require for you to go somewhere else. So we set all that arrangements up for you. If you're going home, we ask that somebody can be available to help you for the first 24/7. Not saying the whole 24 hours of the day, but being there as much as possible because you're making that transition from the hospital to your home to get re-equipped with everything, okay? So some of your options are to go home with home health therapy, where therapy comes into your home 3 times a week and does the exercises with you. The other option is to go to an outpatient facility, meaning a freestanding rehab facility. Over here, Trident Sports is over here. There's some other freestanding places that you know of. Again, we try and set people up if they're going to outpatient rehab. That's close to your area so you're not driving all the way here to Trident, okay? If you're going to an outpatient physical therapy, you have to have somebody with you because you have to have somebody to be able to drive you. You will not be allowed to drive once you leave the hospital, at least for the first 2 to 3 weeks. Until you make your recommendation or your follow-up with the doctor, do not drive, okay? So once you follow up with the doctor, he can pretty much tell you when you can drive again. So you definitely need somebody to take you to outpatient. But home health, if that's your option, they're going to come out again. They're going to come out 3 times a week, show you the exercises, work with you 3 times. Now, when they're not working with you and they don't come out and you don't go to that outpatient rehab facility, you need to still be doing exercises, okay? So just because therapy or a therapist isn't coming on Tuesday, they're coming on Wednesday, you still need to do something, okay? You don't want to get stiff. You don't want to get sore. You want to keep that joint moving. It's very, very important that you guys continue with those exercises. because they're pretty much going to be with you for a month. Once their month is done, you still need to do those exercises, okay? It's very, very important. If, again, there's nobody with you and you need to go to a skilled nursing facility or an inpatient rehab, we set all that up. Case management will see you typically post-op day 1, kind of get a general idea of what your plan is for discharge, what you plan on doing, and if it is inpatient rehab, they're going to give you a list of facilities. You're certainly welcome at that time, if you have not already done, maybe send some family members and friends or whoever you trust to kind of tour those areas just to see which one they think you might like better, okay? But we work very closely with nursing, we work very closely with therapy, we work closely with your doctors and case management. It's a collaborative effort that we're all trying to get you to the best and the safest discharge plan available to you. Information that you're going to be given prior to leaving the hospital. Of course, we're going to give you your discharge instructions. We're going to tell you exactly when you may need to call the physician. But for the most part, if you have a question or concern about anything, call your doctor's office. Call and talk to the the physician assistant or even their nurse. That can just save you a peace of mind, or rather a trip to the ER. Okay, so call the physician's office first if you have a question. We're going to tell you how to keep the incision clean, what you need to do, whether you need to keep it covered or not, depending upon if it's staples or it's not staples, the closing incision. You may want to keep it covered, you may not want to keep it covered, okay? Showering. You are going to be allowed to shower once you go home. But we don't want you to submerge in water. We don't want you to take a bath. We want you to pretty much get in, wash your body, clean that incision, but don't let the water constantly run on it, okay? We want to get it out of the water as much as possible, okay? But you're certainly not going to be restricted not to shower. And then pain control. We're going to give you your prescriptions for your pain medicine and also that blood thinner. And if the doctor did by any chance start a medication you're not familiar with, we're going to give you additional information on that just to kind of make you feel better about taking that medication, okay?